changes, but I can tell you that when I was in medical school, one of the craziest stories that I watched was my surgery professor, and I trained at Mount Sinai in the city, had a patient come through the door who was a woman who had a procedure that sort of went south, but it wasn't the fault of the surgeon, and she sued my professor. And the case was thrown out due to frivolity of lawsuit. That's what it was called. They threw out the case. And she came back 3 weeks after the court case had settled, and my professor had to take time off of work. She wasn't reimbursed. She lost her salary. She had to pay for the court time. And the woman came back into the same office, and she was back, and my professor turned to me and said, that's the woman that just sued me. She said, can you please tell her, ask her why she's here? So I went out as the medical student in my little white coat looking like Grey's Anatomy, and I said, excuse me, why are you here? And she said, it wasn't personal. So it was like, you know, there was this craziness of, from the doctor's perspective of some of these changes happening, of this frivolity of lawsuit, you know, and we'll talk about that a little, but that was one crazy story of things that I've seen. I've grown up, my father's an OBGYN, my brother's a plastic surgeon, I've come from a long line of doctors. I'm currently not practicing, and I can say that there's a lot of disillusionment when it comes to medicine. And if my children today who are being schooled in the Westport Public School District were to go into medicine, I would probably strongly discourage them. Because I think that and I don't know if I'm alone, we can hear from the panel, I'm not sure how anybody feels, but it's tough, I think, and I think a lot of the changes, we're not sure what's to come, with the amount of money that it costs to go to medical school these days, and the amount of money that it costs to have malpractice insurance, which is tremendous. Many doctors aren't making enough to support themselves, and we start to see shrinking doctors, especially the OBGYNs. A lot of the local practices up here, people are afraid to practice OB. And I'm seeing it as a women's health specialist that a lot of doctors, they're shrinking. The number of doctors in primary care is shrinking because they're afraid to practice and they can't afford to practice. So we'll talk about that a little. But one statistic I wanted to read you is that in this survey for American physicians, they surveyed about 3,500 physicians nationwide, and 60.6%, it's 60% of physicians, 2 out of 3, say they would retire today if they could. And that was up from 45% in 2008, so that went up about 15%. 33.5% said they wouldn't go into medicine if they could do it all over again, so that's a third of doctors. Physicians are seeing 16.6% fewer patients per day than they did in 2008, a decline that could lead to 10 to millions of fewer patients seen per year. And over 52% of the physicians have limited access to Medicare patients, have limited their access to Medicare patients, and they're planning to continue to limit their access. So on that note, Scott, I think, yeah. Scott's one of our, knows a little bit more about me than Medicare, but he just prepared a.
Excluded Medicare.
What's that?
They have not limited them to. Have not limited
the physicians are trying to limit the amount of Medicare patients that they're seeing. Yeah. So,
yeah. Thanks. It's a pleasure to be here. My wife and I moved to Westport in June with our 2 3-year-old girls, and it's a pleasure to be part of the town. Just by way of a little background, I had worked in the last administration as Deputy Commissioner of the Food and Drug Administration, and then before that I had worked at Medicare and Medicaid. So I worked on some of these policy issues in the Bush administration, so that's by way of disclosure. And I'm also working as a healthcare advisor to Governor Romney. So while I'm not here tonight to speak for the candidate or speak for the campaign, I just want to give you that context, my point of view. Unfortunately, I'm going to be a little bit pessimistic at the outlook in terms of what I think we're going to see under the President's healthcare plan, under the Obama healthcare plan. A lot of what Jenna talked about is obviously dependent upon whether he wins re-election, because Governor Romney has committed to repeal most, if not all, of the healthcare plan. But speaking for a moment as if the healthcare plan did go forward, if the president were to win re-election, I want to talk about what I see as some of the aspects of the bill that I find the most troubling. I think when you peel away the healthcare bill, what it does really is fundamentally remake the practice of medicine in the country. There's a lot of different things we talk about with the legislation in terms of how it's going to remake the wage-labor relationship in employers, and how it's going to remake different aspects of the medical complex and the pharmaceutical industry, the medical device industry. But I think fundamentally it really does transform medical practice in the country. And I want to talk about 3 ways I think that that's going to happen. And I'll touch on the first. The first is that the healthcare bill really transfers the risk of practicing medicine, the actuarial risk, if you will, of taking care of patients, from insurance companies who've traditionally borne the actuarial risk onto doctors. embedded in the legislation. When the president talks about the reforms in the legislation that were put in there to try to drive down healthcare costs, really the only thing that's in the bill that tries to address issues of cost are what they do with respect to how they reimburse under Medicare. There's nothing else in the bill. Most of it's just Medicare payment reform. The rest of the bill really is just an expansion, a health insurance expansion bill, an access bill, if you will. And if you look at the payment reforms, what they did in Medicare to try to drive down costs in the Medicare program, on the assumption that the Medicare program comprises such a large portion of the market that what they do in Medicare will end up influencing pricing in the rest of the market, really what they do are just fall back to different forms of capitation. You all remember in the 1990s when HMOs started to capitate physicians. They gave them lump sums of money to take care of large groups of patients and basically put the risk on the doctors, the financial risk for taking care of patients, onto the doctors, and gave doctors a very strong financial interest to try to economize on utilization of services. When you look at what they did in Medicare, how they reform payment Medicare, everything they've done are just forms of capitation. They talk about accountable care organizations, which basically is giving large integrated medical practices lump sums of money to take care of groups of patients that get assigned to them. They talk about bundled payments, which is basically giving doctors lump sums of money to take care of patients with certain conditions. So a patient who presents with stage 1 breast cancer, the doctor might get $70,000 to take care of that patient. And if the doctor ends up spending more money managing the patient, they're going to have to bear the cost of that. They talk about medical homes. Basically, a medical home is just capitated primary care. Under Medicare, patients will be assigned to primary care physicians. That primary care physician will be, again, given a lump sum of money to take care of the patient, to manage their overall medical care. But in this case, the primary care physician will be capitated. So it's really just a throwback to the old model of capitation in the 1990s. Now it works. It does drive down costs. And if you look what happened in the 90s when the HMOs first came about, they did slow medical spending and actually drive down spending, drive down overall cost increases for a number of years. But there was a backlash to it. Patients didn't want their doctors to have a financial disincentive to provide care. And you saw things like the Patient's Bill of Rights get introduced into Congress. Never passed Congress, but got introduced. And then you saw the HMOs move away from this model. They went towards, PPOs and other more looser models where patients weren't so narrowly assigned to certain physicians. My concern about it is that I think when you're looking at the healthcare system generally, the reality is someone in the healthcare system is going to have to consider costs at the time of utilization. You can either have the government do it through very prescriptive means of setting rules about what patients can and can't have in different medical encounters. You can do what we tried to do in the last administration, which was go towards more consumer-directed insurance, where patients are exposed to more of the costs of their decisions. You see more co-pays and more deductibles. So the onus of trying to consider costs and economize is put on the patient. I think the least transparent place to put the economic consideration, if you will, is on the physician. Because most patients won't know what wasn't made available to them because their physician had an economic incentive not to overprescribe something or not to make the full panoply of treatments available because of their costs. If the government does it, you see it. It's very public. If the onus is put on you as a patient, you see that as well because you're burdened by the co-pays, the deductibles. But when the onus is put on the physician, I think it's the least transparent place to do it. And that's what worries me about the reforms that are in the Affordable Care Act. The second